at RSNA with Dr. Woznitza, and we will be talking today about AI-driven lung cancer pathways. Dr. Nick is a consultant radiographer and clinical academician at UCLH NHS Trust, and he also wears another academic clinical hat with the Canterbury Christchurch University, and that's a capacity we have done quite a lot of work with Dr. Nick on generating evidence within the NHS, which is a fairly representative but complex health system. He's also an honorary associate professor at University College London and is a renowned reporting radiographer with over 20 years of experience, including evidence generation pieces across radiographer reporting as well as AI. And he is the joint lead of a live clinical trial within the UK called the Lung Impact Trial, which is looking at the potential of AI to reduce times to diagnosis by speeding up the lung cancer pathway. It's a pleasure to have you with us, Nick.
Thank you so much, Ravi. It's a pleasure to be here.
Nick, just to set a bit of context, within the lung cancer pathway, we often hear that diagnosis is fairly delayed or late stage. What are the challenges that exist and what makes it such a difficult diagnosis and treatment process?
So I think lung cancer is a thorny problem because it often presents late. The initial symptoms of cough, weight loss are very non-specific. We know that lung cancer is also more prevalent in more deprived populations, so lower income threshold in the UK, people who don't have English as a first language, or those that live in regional or more remote communities. And so when you have a disease which often presents late, has very vague and non-specific symptoms, often causing the patient to go for the X-ray in the first place can be delayed. In the NHS, we have capacity problems with workforce, with scanner shortages. That actually means that not only once a patient arrives at the hospital, there can often be a delay in getting that X-ray reported.
Correct. And of late, there has been a lot of talk around lung cancer screening as a way of diagnosing cancer earlier, improving patient outcomes, better survival. And the UK in particular has invested significantly in terms of lung cancer screening. Where do you think that aligns with the overall cancer incidence, and what are the limitations of the programs in itself?
Yep. So we know there is robust trial evidence from the Nelson study, from the NLST in the United States, showing that lung cancer screening with low-dose chest CT produces a stage shift and improvement in lung cancer mortality. We know that. That's got really, really great evidence. However, now that we're adopting the targeted lung health checks, which involve eligible patients for a low-dose lung cancer screening in the UK, we're actually only expecting to find a quarter of lung cancers through a screening program. Either the patients themselves won't be eligible, so we know that lung cancer in never smokers is rising. They're not eligible to be part of a lung cancer screening program. They may exceed the age range, but also engaging asymptomatic people into a screening program, especially given the deprivation gap with lung cancer, means that we only expect half of the patients to enroll with the screening program, and then only a quarter of lung cancers to be found through lung cancer screening. So the role of chest X-ray and symptomatic diagnosis of lung cancer using chest X-rays is still going to play a really, really, really important role if we're looking to reduce the deaths from lung cancer.
And you mentioned chest X-rays, right? As if today that is the first diagnostic test per se that a patient would have from a GP referral pathway. Of course, the NHS does millions of scans on an annual basis. What are the things that need to be looked at from a lung cancer pathway perspective on a chest X-ray? And why are there gaps right now in terms of delayed diagnosis and time to diagnosis?
Yeah. So in England, not even the UK, just in England, every year 7 million chest X-rays are done. About nearly 2 million of those are done from a primary care referral. So the patient's in their GP or their primary care physician and gets referred in for a chest X-ray. So 2 million X-rays is quite a high volume. We have the capacity constraints around both the acquisition of the imaging, the reporting of the imaging, and then scheduling an appointment for a CT scan. And so the We also know that evidence suggests that primary care physicians who refer more people for chest x-rays find lung cancer sooner. We know that. So what we need to do is not only increase awareness within patients about symptoms of lung cancer to get them to their doctor, we need to increase the numbers of x-rays being referred by their doctor, and then once the x-rays are being taken, we need to be able to provide really prompt, accurate results.
It's interesting that you mentioned the whole pathway there, right from the referral to the chest x-ray to the chest x-ray report. If there is something suspicious, then the CT referral. So there's a whole pathway and a lot of time and steps along the pathway till somebody gets to a confirmed diagnosis. I know you have done a clinical trial called the RadioX trial, which has significantly shown positive results for impact on time to diagnosis. Would love to know more about you, about that.
Okay, thanks. Yeah, so Cancer Research UK funded the RadioX trial. It started in 2017, and what we found was for the year we had consecutive referrals for GP chest x-rays, and what we found was that by giving patients the result of their chest x-ray at the time of the examination, so they waited in the department, we told them the result. For those where it was an abnormal and possible lung cancer, we offered the patient a CT scan at the time. By doing that, we reduced the time to diagnosis from lung cancer from 63 to 32 days, a massive difference. When we look to scale this across England, we know now that there's about 1.82 million chest x-rays every year from primary care. It's not feasible to be able to provide an immediate report for all of those examinations.
Correct. In fact, the NHS is also struggling with backlogs on plain films. So the capacity that needs to be prioritized for lung cancer X-ray reporting is just not there. One of the things that the Lung Impact trial is looking at is, can AI help bridge that gap? Do you want to walk us through what the trial is?
Yes, I'd love to. So Lung Impact is, I think, one of the only prospective multi-site randomized trials to look at the impact of artificial intelligence triage of abnormal chest x-rays on the time to diagnosis of lung cancer. We are block randomizing at days at multiple sites across England to look at, can an AI solution flag abnormal chest x-rays, prioritize these ones for immediate review. When the reporter determines that the x-ray is abnormal and requires a CT scan, they're then able to communicate that to the patient and offer them a same-day scan.
Correct. So essentially it's taking the same pathway, it's trying to bring efficiency along the pathway by making sure that the right capacity goes to the right scans and potentially brings us to results similar to the RadioX trial, hopefully.
Yeah, hopefully.
Yeah.
And I think when we're looking at the lung pathway, so we have median waiting time data available for all of England. So at an England level, it takes 26 days from being referred from a chest x-ray to having your CT scan reported. The National Optimal Lung Cancer Pathway in the UK asks for that to be done within 3 days. So we need to try something different.
Correct. And the National Optimal Lung Cancer Pathway has been around for a while. It's a national standard. AI can potentially help with the feasibility and making it a reality. Where are we with the trial today in terms of what are the sites and any early results that you can potentially talk about?
So we are now live in 3 sites in the United Kingdom, University College Hospital, Ipswich and Leicester. We've month sort of 2 or 3, so lung cancer data hasn't come through. We're processing, I think we've processed our first nearly 10,000 chest x-rays from the 3 trial sites, and that's expected now they're fully online to ramp up quite quickly. So we're quite confident that as the further sites come on board and our accruals go, we'll be really well powered to find out how we can best identify patients who need our urgent care.
Especially given the climate in the UK right now and the pressures in the NHS and plain film being a priority. Hopefully the work that you're doing with Lung Impact can educate and inform a lot of the discourse around how AI should be adopted in clinical practice and the benefits it can drive for the patients as well as the clinicians. It's a pleasure having you here as usual, Nick, and hopefully when we meet again, we hear the results and expected success from the project.
Yeah, well, we're hoping the interim analysis will be ready in spring 2024, and hopefully we'll be able to share it here next year in Chicago.
Sounds wonderful. Thank
Lovely.
you so much.
Thanks so much, Ravi.